Assalamu alaikum everyone. The next topic of discussion is CLL, which is known as chronic lymphocytic leukemia. CLL is a type of B cell malignancy that manifests with lymphocytic leukocytosis. Lymphocytes are elevated. CLL is most common type of leukemia in adults and is typically diagnosed in older individuals greater than 65 years of age. Clinical features include painless lymphadenopathy, fatigue, chronic pruritus, and increased susceptibility to infection. Diagnosis require persistent monoclonal B-cell lymphocytosis greater than 5,000 cells per mm³ for greater or equal to 3 months, with immunophenotype marker consistent with CLL and flow cytometry. Peripheral smear typically show high percentage of small mature lymphocytes and smudge cells, also known as Gumpert shadows. Definition: So CLL is a type of proliferative B-cell malignancy that manifests with lymphocytic leukocytosis. Small lymphocytic lymphoma is also a derivative of B-cell with same genetic and molecular markers as CLL, but it primarily manifests in lymph node, bone marrow, and other lymphatic tissue rather than with leukocytosis. Some sources classify CLL as a low-grade non-Hodgkin lymphoma because the origin cell is a mature B lymphocyte. However, as the malignant cells are present in blood, it's considered to be leukemia. Small lymphocytic lymphoma is a manifestation of this condition in lymphatic tissue and is therefore considered to be a lymphoma. Epidemiology mainly affects the males, and the median age at the time of diagnosis is 70 to 72 years. Most common type of leukemia in adults. Etiology: risk factors are old age, environmental factors like organic solvent and family history. Pathophysiology: we have acquired mutation in the hematopoietic stem cells. There will be increased proliferation of the leukemic B cell with impaired maturation and differentiation in the marrow, resulting in suppression of the proliferation of normal blood cells, which leads to immunosuppression, thrombocytopenia, and anemia. Immunosuppression is due to hypogammaglobulinemia, antibody deficiency due to both the suppression of the normal B cell proliferation in the marrow and the increased proliferation of the dysfunctional leukemic B cells that do not produce functional antibodies, and granulocytopenia. Then we have thrombocytopenia, anemia, and infiltration of the lymph node, liver, and spleen. So these two are the underlying pathophysiological mechanisms. One is the suppression of the proliferation of the nervous cell, while the second is infiltration of the lymph node, liver, and spleen. Clinical features: about half of the cases remain asymptomatic for a long period of time, resulting in late or incidental diagnosis. There will be B symptoms: painless lymphadenopathy, hepatomegaly, and splenomegaly. There will be repeated infections, severe bacterial infections, mycosis, fungal infection, and viral infection. There will be symptom of anemia and thrombocytopenia and dermatological symptoms like leukemia, cutis, chronic pruritus, chronic urticaria. Lymphadenopathy is typical in lymphoid malignancies such as CLL and helps differentiate CLL from CML, a myeloid malignancy. So lymphadenopathy is a typical finding in lymphoid malignancy, not in myeloid. Diagnosis: we have diagnostic criteria for the CLL that is persistent, greater or equal to 3 months of lymphocytosis, which will be greater or equal to 5,000 cells per mm³, and CLL immunophenotype confirmed by flow cytometry, including expression of CD5, CD19, CD20, CD23, and light chain restriction kappa or lambda. Additional finding: we have cytopenias leading to anemia, thrombocytopenia, granulocytopenia, anemia caused by autoimmune hemolytic anemia. Peripheral smear may show a high percentage of small mature lymphocytes, and there will be smudge cells, Gumpert shadows. Mature lymphocytes that rupture easily appear as artifact on blood smears. So these two will be the finding. There will be a lot of small mature lymphocytes and there will be smudge cells. These are the small mature lymphocytes which are large in number, and these are the Gumpert shadows or smudge cells. This picture also shows a lot of small lymphocytes and smudge cells. Occurrence of both autoimmune hemolytic anemia and ITP is known as E1 syndrome. In CLL, smudge cells appear on smears like a crushed lateral lymphocytes, CLL. Crushed lateral lymphocytes known as smudge cell. Prognostic markers in CLL are advised in patients with confirmed CLL diagnosis. Methods are cytogenetic testing and serum studies. Cytogenetic testing: we do FISH analysis, assess for the common structural chromosomal aberration, for example, deletion of 17p. immunoglobulin heavy chain variable region mutational status IgHV, and T53 mutation status. In serum study, we have beta-2 microglobulin and LDH levels. Interpretation of the results or adverse prognosis will be when there is finding of deletion of 17p, deletion of 11q, T53 mutation, elevated beta-2 or elevated LDH. These will show the adverse prognosis. Intermediate prognosis when there is a finding of trisomy 12, and the favorable prognosis when there is presence of the IgHV mutations, immunoglobulin heavy chain variable region G, and isolated deletion of 13q. So these two will give the favorable prognosis, while other trisomy 12 will give intermediate, and these all will give the worse prognosis. Biopsy, so it's not routinely required but considered in patient with cytopenias to determine the cause. Typically finding will be high percentage of small mature lymphocytes. So these will be the finding on the biopsy. For the classification of CLL, RAI staging system is used. We have RAI staging system in which RAI stage 0, 1, 2, 3 and 4 and modified RAI stage 0 is included in low risk, 1 is intermediate risk and 2, 3 and 4 are included in high risk according to modified RAI staging. What will be the findings? So in RAI stage 0 there will be only lymphocytosis, isolated lymphocytosis. In stage 1 lymphocytosis will be present and in addition with lymphadenopathy. In stage 2 there will be additional hepatomegaly and splenomegaly with lymphadenopathy and lymphocytosis. In stage 3 there will be additional anemia along with all these findings, and in stage 4 there will be thrombocytopenia as well in addition to above all these findings. And we have different types of differential diagnosis of like ALL, autoimmune hemolytic anemia, mantle cell lymphoma and hairy cell lymphoma for the CLL. Treatment of CLL is based on the disease risk, RAI staging and disease activity. Low risk disease, for example, RAI stage 0, so close monitoring is done. Intermediate risk disease, RAI stage 1 or 2, consider close monitoring if stable and asymptomatic. Medical therapy indicated for progressive or symptomatic disease. High risk disease, stage 3 or 4, so medical therapy is given. Anti-cancer therapy may include targeted therapy like ibrutinib, rituximab, alpetrozumab. Chemoimmunotherapy, for example, FCR, fludarabine, cyclophosphamide, and rituximab. And allogeneic stem cell transplantation currently only curative treatment options, not routinely performed, but it's the only curative option. CLL is a malignancy with slow rate of cell division and disease progression. Treatment of low risk disease is usually not recommended. Complications, so there will be immunosuppressions, so there will be infections, most common cause of death. So infections are the most common cause of death. Secondary malignancy, hyperviscosity syndrome, and autoimmune hemolytic anemia, both warm and cold type can occur. Rectal transformation or Richter syndrome. So it's a high-grade non-Hodgkin lymphoma, usually diffuse large B-cell lymphoma. Diagnostic indicators are rapidly progressive lymphadenopathy, so lymph node biopsy is required. There will be new onset of B symptom and there will be elevated LDH. Treatment similar to the symptomatic CLL in advanced stages. Prognostic factors: older age is associated with overall poor prognosis, RAI staging, adverse prognostic marker in CLL, example deletion of 17p, elevated beta-2 microglobulin level, and blood lymphocyte doubling time. Rapid doubling is associated with high risk of the disease. So these are all the prognostic factors for the CLL.